While people are signing in, I just want to highlight a couple new things, kind of administrative wise for the PKDRC. This will be our final roundtable for this, I guess, academic year, if you will. We will take a break for the summer. So Christopher, you happen to be our last speaker of the year. And we will reconvene again sometime, hopefully in September, I think is the plan for we'll start with the roundtables again. If anybody here has suggestions for speakers, we would love to hear it. So please forward names that you would like to have speak at this roundtable. We'll try to get them in. And we have several new resources I want to highlight. There's on the clinical resource and biomaterials, there's a new PKD data dictionary up on the site. We have a new in vivo PKD patient variant missense model that's available. Several new antibodies, monoclonal antibodies have been generated that are up on the molecular subcommittee core. These will be available soon if they're not already there for distribution. If you have questions about that, please let us know. And so with that, that's administrative wise what I have to discuss. I want to introduce today's speaker, Christopher Manek, he's assistant professor from the University of Arizona and Department of Physiology. He is one of our pilot and feasibility awardees. So congratulations on that. He will be telling us about renal denervation and its impact on renal cystogenesis in a mouse model of ARPKD. At the end of this, please raise your hand and unmute yourself if you have questions. And I encourage you to do that because it fosters more interactions than me reading it off of a chat. It's just a better conversation. So just please do that if you don't mind. So Christopher, I'm going to turn it over to you. Again, thank you for taking the time to meet with us. We look forward to hearing what you have to say.
All right. Thank you very much for the opportunity. Let me make sure I get this screen shared. Okay. Let's make sure. Can you all see my slides? I'm looking for nods. Okay, good. Thank you. All right. So thank you for that introduction. So what I'm going to be talking about is our new application of renal denervation in a model of PKD, specifically within ARPKD. And so I'm going to try to keep this brief. I was told to keep this about 20 minutes. So it should facilitate some good questions and discussion afterwards, and hopefully ignite some collaborative opportunities as well. So before we dive in, I'd like to just start off with a very general anatomy lesson, because I want to make sure that we're all starting off from the same point. So I want to make sure that everyone is aware that the kidney has nerves. Okay, it has descending sympathetic nerves all throughout the kidney. So this is the
I have it on my calendar.
This is the postganglionic efferent sympathetic nerves. They terminate all throughout the kidney, the cortex, the medulla, the pelvis.
It's in, she sent it in.
Sorry, guys. Can you make sure that you're muting yourself?
Arlene sent
Sorry,
it
Christopher.
in.
That's okay.
Yeah.
Jessica Hunt, will you please mute yourself?
Okay. All right. So in addition to the sympathetic termination all throughout the kidney of the descending sympathetic nerves, I also want to recognize that there are ascending sensory nerves that also terminate all throughout the kidney. So in the cortex, the medulla, and the pelvis. So what do they do? It's pretty well established that the sympathetic descending signals contribute to the JG release of renin and the activation of the renin-angiotensin system, as well as sodium retention in the proximal tubule and the regulation of renal blood flow. The afferent nerves, their function is a little bit more nebulous. It's thought that they serve as a sympatho-excitatory reflex when activated under instances of maybe renal ischemia or chemical or electrical stimulation. But there's also an idea in the field driven by Ulla Kopp and others that show that the activation of the afferent nerves also cause a sympatho-inhibition of the contralateral kidneys sympathetic nerves, which result in a natriuretic or diuretic effect. But so their overall function is kind of still out there, a little bit more nebulous, and that's kind of where I'm trying to fill a gap. So starting off in a very general central hypothesis that my lab functions on is that disease states such as hypertension, cardiovascular disease, or chronic kidney disease stimulated by things like such as high salt intake, high fat diet, or a genetic predisposition are driven in part by an aberrant change in the autonomic nervous system, particularly through the sympathetic nerves. And this is regulated through 4 main beds, we'll just say, within the sympathetic system. That's the cardiac. Now, let me put see if I can put my laser pointer on. That's through the cardiac, the splanchnic, the renal, and the muscle sympathetic nerves, the regulation. And particular attention has been paid to the renal sympathetic nerves, as if you ablate these nerves or interrupt this nerve signal, it's been shown to improve many of these disease cases, specifically within hypertension. And that's where I made my bones during the early stage of my career, is within the context of salt-sensitive hypertension. So in a model of salt-sensitive hypertension using the DOCA salt model, we showed that the renal nerves contribute to the early stage development of the disease, as well as the maintenance in late stage of the disease. So the early stage here, you see that in the sham group. These are DOCA salt animals given a sham renal denervation, so they have innervated kidneys, develops a hypertension progressively over these 3 weeks. And you see that this TRDNX group, so that stands for total renal denervation, that's getting rid of all renal nerves, attenuates that progression in the early stage of the disease. Notably, we have a really cool technique in which we can just take away sensory nerves, but leave descending sympathetic nerves intact. And that treatment effectively had about the same antihypertensive effect in the early stages of the DOCA salt progression, as well as the late phase of the disease as well. Both total and afferent targeted renal denervation drop blood pressure in this late stage of disease. So it suggests that renal nerves contribute to the progression and maintenance of hypertension in this model. And largely the afferent nerves seem to be playing a very central role in both of these phases. Going further, I developed a way to record from these nerves. So this is a multi-unit nerve recording technique in which we go in and hook it with a bipolar electrode, record nerve activity, and we section the central end of that nerve, and we're recording only afferent nerve activity. And since this is a multi-unit nerve recording, we need some way to normalize across the animals. And so how we do that is we just use a maximal stimulus with capsaicin. This will stimulate the TRPV1 receptors that are all within those sensory nerves, causing maximal activation. And then we will look at that resting afferent nerve activity as a percentage of maximal activation. And this is just a little picture of grabbing one of those nerves before I encase it in silicone. Okay. So in a model, the same model, that DOCA salt hypertension model, we took either normotensive vehicle control, so they didn't receive either the high salt or the DOCA, so they're normotensive, and compare them to the hypertensive DOCA animals. And we record sympathetic nerve activity. We perform that that proximal section to record only afferent nerve activity, which you see here between the vehicle and DOCA animals. And then we perform at the very end a distal section, which isolates just electrical noise, which can be subtracted from the rest of the signal. So like I was saying earlier, how we need to normalize this data because it's a multi-unit nerve recording across animals. And so we have a raw nerve activity which is then rectified and integrated over time. We take this baseline nerve activity and express it as a percentage of the maximal activation following capsaicin within the kidney. And so even if you're just looking at raw integrated nerve activity or normalized to capsaicin, we see about a twofold increase in this afferent nerve activity, this renal afferent nerve activity in the DOCA animals versus the vehicle controls. And so the afferent nerves seem to be playing a crucial role in the development of the hypertension through the activation of these nerves. And so that's enough about hypertension, because I just wanted to give you a little bit of context about how I got to here. Because I wanted to look beyond just hypertension in that we saw a lot of beneficial effects of renal denervation that weren't not necessarily just related to blood pressure. And so we were looking for other potential targets to apply this renal denervation technique and maybe evaluate what renal afferent nerve activity is doing in those disease states. And that's what's largely brought me to PKD. And obviously this audience needs no introduction to PKD, but I want to highlight the reason why I was so attracted to pursuing the early experiments in this area was that these patients often present with hypertension, lower flank referred pain, and renal inflammation and fibrosis. We've seen that the application of renal denervation can do a pretty good job of attenuating hypertension. And in some of our recent papers, we've also seen that that does a nice job of attenuating renal inflammation. And the fact that they present with lower flank pain really struck me as a potential model in which they have this elevated afferent nerve activity. And so that's what brought me here. And so I just want to also highlight that the treatments of PKD at large, so both AD-PKD and AR-PKD, are very, very limited. And they eventually will need a kidney transplant within their lifetimes. And they're largely strictly limited to dialysis at the late stage of disease. And the first pharmacological intervention that's approved was just in 2018 with the release of tolvaptan, the V2 blockade. But I also just want to highlight that this is known to have some negative side effects and relatively impacting the quality of life of these patients, such as polyuria, polydipsia, and potential liver toxicity in some of these patients when they're taking it for a very long time. And so that really highlighted potentially an unmet need in which maybe renal denervation could fill that need. So I just want to highlight again that these patients present with hypertension, renal inflammation, and lower flank pain. And this may be largely also related to the increase in this vasopressin pathway, as seen with the chronic V2 blockade. It shows a really nice blunting of the cystic progression in both preclinical and clinical models. I want to highlight that there's also a neuroanatomical connection between vasopressin and the afferent renal nerves. If you activate the renal nerves electrically or chemically, you can cause an increase release of vasopressin acutely. And this is largely driven through the just simple neuroanatomical innervation and termination within the PVN. And as you can see here, this also regulates some of the cardiovascular centers in the brain, such as the NTS and the RBLM. And so the early hypothesis that we wanted to test within a model of PKD was that renal nerves, potentially through afferent nerves, increase in afferent nerve activity, contribute to the progression of the cardiovascular and renal dysfunction in this model. And so we were able to get our hands on the PCK rat. So we wanted to stay in the rat in the beginning, because this is where we did a lot of our nerve recordings and surgical interventions. And so we were lucky enough to get that model in our hands. And so using this model, which is a model of AR-PKD because of the dysfunctional PKHD1 gene within this model, we wanted to address the question, very simple question: do they have elevated afferent nerve activity in the PCK rat versus their non-cystic controls? And is there a role for renal denervation in the blunting of the PKD cardiovascular renal disease progression in this model? And so these studies were driven by my PhD student that just graduated actually this last February. We went in and recorded afferent nerves in these cystic kidneys, just like what I described to you earlier, where you isolate a renal nerve bundle. And then to isolate afferent renal nerve activity, we section the proximal side of this nerve and record only afferent nerves. And then we normalize to a maximal activation with capsaicin. And we saw that in PCK rats at 10 weeks of age, so fairly early on in their disease progression, at 10 weeks of age, the PCK rats have an elevated afferent nerve activity compared to the Sprague-Dawley non-cystic controls. The PCK rat background is on a Sprague-Dawley, and that's why we're using that as a control. And if we break that down between males and females, you see that that's relatively maintained between the male and female cohorts. We also performed a linear regression of cystic index versus afferent nerve activity, which addresses the question of is afferent renal nerve activity driven by an increase in cystic index. And it seems to be that case because there's a positive, significant correlation. The higher the cystic index, the higher the afferent nerve activity. But this obviously points to the question, the classic question, chicken or egg, which is driving which? And so what we're going to do is just go in and do what we do best. We record from these nerves, but we also can do the renal denervation technique. So we go in and also cut those and then see the response following. And so we're going to look at this in two different paradigms. Just like we did in the hypertensive model, we're going to look at the early phase of the disease. Can we blunt the progression early on? And then in the late phase of the disease, can we attenuate its progression or maybe even reverse it? So to go a little bit more into how we do the renal denervation technique is we perform a midline incision, expose the renal arteries, and then either go in and physically dissect off the nerves that follow along the renal artery, and then follow that up with a phenol ethanol solution that is just kind of painted onto the renal artery. That does a pretty good job of cutting the descending sympathetic nerves as well as the afferent nerves. We're also going to target just the afferent nerves in this model, just like we did with the hypertension model. And how we do that is we use a very, very high concentration of capsaicin. And that is just soaked, we dip gauze in that solution and wrap the renal artery and expose those nerves for about 10 minutes to this very high concentration of capsaicin, that spicy little ingredient in chili peppers. And that does a good job of targeting just the nerves that express the TRPV1 receptors, which are sensory nerves, and leaving these descending sympathetic nerves intact. And so for the early phase progression, we're going to do the treatment surgeries, either total or afferent targeted denervation at 4 weeks of age. And then we're going to follow them out to 10 weeks to see how that affected the cystogenesis as well as their cardiovascular phenotype. At 8 weeks of age, when they're large enough, that's when we implanted the telemeters to monitor 24-hour blood pressure. So in this, this is a paper that we published in AJP back in 2020 or 2022. We showed that 6 weeks following denervation, total denervation, we dropped blood pressure in these animals by about 10 millimeters of mercury. That's not necessarily surprising. We see that very consistently across many disease states, including just a Sprague-Dawley. If you do a total renal denervation, you're going to drop blood pressure by about 5 to 10 millimeters of mercury. So that wasn't necessarily that surprising. Afferent denervation, we did not detect a change in blood pressure in this phenotype, but I would argue that they're not necessarily hypertensive at this age either. And so I guess that's not necessarily surprising either. And this phenotype or the effect of renal denervation is relatively shared between the males and females. So we're not necessarily seeing much of a sex difference, at least on the cardiovascular phenotype. But what was surprising to us is that renal denervation attenuated the cystic progression in this model. So when performed at week 4 of age, and then we monitor that or assess cystic index at week 10, we saw that total denervation attenuated the cystic progression in this model, and afferent targeted denervation had a very similar anti-cystic effect, and this is relatively shared between the male and female cohorts, highlighting that we don't really have much of a sex difference in this case. We thought that this was just remarkable because we did not necessarily expect much of a cystic effect, because we've only looked at cardiovascular phenotypes, and therefore that was kind of the only thing that we expected. So we were very surprised by this overall effect. And I just want to highlight that the really cool part of this is that renal denervation, when compared to a similar study that gave a chronic V2 blockade over the exact same timeline, the week 4 to week 10 timeline, we see a very similar anti-cystic effect. Yet we do not have the polydipsia and polyuria that are associated with this chronic V2R blockade. So we thought that was extremely exciting. And that's what brought us to the PKD-RRC pilot and feasibility award. That's why we wanted to continue to progress with this story. And so we're going to be looking at the late phase of the disease now, because we've shown that this blunts the early phase. But what about when the cysts are much more advanced? Can we just blunt its further progression at that point, or maybe even reduce their cyst size and burden? Or on the cardiovascular or functional effect, can we reduce blood pressure and or improve renal function? And so these are in 6-week-old animals. We do the denervation techniques, either the total denervation or afferent denervation at 24 weeks. We follow them out to 30 weeks, and we do the exact same analysis. And we were surprised to see that there was a blunting at this stage of the disease with total denervation as well as afferent denervation compared to the sham controls. So even in the late form of the disease, we're blunting the progression. I want to highlight also that GFR at week 24 or at baseline, the week 0, was fairly consistent at baseline across treatment groups. And following treatment, 6 weeks post-treatment, we detected a decrease in GFR in the sham controls, where we did not detect a change in GFR compared to baseline in either treatment, which would suggest that this attenuated a decline in kidney function in this model. So we're improving the cystic profile in this model, as well as the potential renal function. And secondly, I also want to highlight that we see an improvement or a decrease in serum copeptin following the treatment, either total denervation or afferent denervation, which highlights that it may be through an AVP mechanism or vasopressin mechanism. Yeah, we have this very wide-ranging effect with both total denervation and afferent denervation. So I'm not necessarily sold on this is exactly the mechanism in which this is working. And I'd be happy to discuss that further if you'd like. So this was very exciting for us to see in this late form of the disease. Obviously, the one explanation is that this just blunts it, just like it did in the early phase of the disease, where it flatlines the progression of the cyst growth, whereas the sham is allowed to go on and have further progression of the disease or cystogenesis. But we cannot rule out the idea that this also reduces size. And we obviously have to do repeated measurement over time in order to support this claim. But we can't rule out either explanation at this point. And so we're following this up right now with repeated measurements via ultrasound as well as MRI to get a very good idea of specifically the cyst volume changes over time following renal denervation to truly address whether it's just simply slowing growth or if we actually do have an effect on the original cyst size. And so I'll summarize it there, and then we can kind of talk a little bit about some very, very new data that just came up in the last week or so in my lab that I'd love to get your opinions on. Thus far, I've shown that renal denervation does a pretty nice job of attenuating the cystic progression in either the early or late phase of the disease. And we think that it may be through this ascending mechanism where at the hypothalamus, this increase in afferent nerve activity, which we demonstrated in the PKD model, activates within the PVN and causes a release in vasopressin. And that may be the mechanism in which it's causing this overall cystogenesis. And so we have several studies in which we're attacking this with our over the next couple of years. We're going to continue our work in the PCK rat, but it's very importantly, we're going to take this just from not only from an AR PKD model, but into an AD PKD model using the nephron-specific PKD1 Cree mouse, as well as the PKD RC mouse. We also have to address what's the underlying cause of this increase in afferent nerve activity and also the timing of it. When does this occur? We think that it may be driven in part by inflammatory cytokines, because this is kind of the story that's developing within the hypertension model. So we see that there may be something shared there between the two models. But I also want to just highlight this last one here, is that I showed earlier a comparison of renal denervation versus tolvaptan. So right now we want to do that in our lab, comparing the two treatments, but also, are there additive effects? Because I love these type of experiments, because this is either if there's no additive effects, cool. It's likely through a very similar mechanism in which we're attacking. But if there are additive effects, even better. I mean, this would be excellent, at least obviously for the patient, if there are additive effects in suppressing cystogenesis. And so this is very, very fresh data. I just wanted to make sure that I got it ready to discuss here, where we're simply just doing a renal denervation. This is just total renal denervation. We're not messing around with afferent denervation right now in this cohort. We're just doing the very clinically applicable renal denervation technique and either adding or subtracting tolvaptan, chronic V2R blockade at week 4 and maintaining this all through week 10 and assessing tissues at the very end. And so what I'm showing you here is systolic blood pressures collected by tail cuff and heart rate. We don't necessarily see much of an effect of the tolvaptan in the sham group here. This is in the green versus the sham chow, either in the males or females. But renal denervation seemed to lower blood pressure slightly in the renal denervation chow compared to the sham chow group. We're not seeing much of an effect, though, in the females here. Heart rate is just generally higher in the females compared to males, but no necessarily treatment effects here. Apologies for the small size here, but this is just showing you over time the effects on water intake, urine output, and then weekly food intake over time. So this is at week 2, 4, and 6 post-treatment. And I just want to highlight that we're not seeing much, a very strong polydipsia and polyuria effects of the tolvaptan, which we would have expected at either week 2, week 4, week 6 in just the males. There's a slight, and I will admit also that it is statistically significant. There's an increase in water intake and urine output with tolvaptan in the males. But I was very, very surprised to see this drastic effect in the females. And so I would really invite a lot of comments on this and seeing whether or not this is seen at the clinical level, because I can't find very much on this in the clinical literature. But I also just want to highlight that over time, they got very similar doses. So this is weekly food intake per body weight. And so their dose of tolvaptan is very similar over time. And so it doesn't seem to be mediated by that. The serum creatinine is not really much of an effect. The blue and the purple are males and females respectively mixed within here. Serum copeptin, it appears that this is increasing with tolvaptan treatments, either in the sham or renal denervation group. So tolvaptan treatment alone seems to cause an increase in vasopressin, which is not necessarily that surprising. It's probably a compensatory effect. But I do want to highlight that we do see serum ALT activity going up, which is a marker of hepatic injury or hepatic dysfunction, which is, I guess, concerning, I guess, for 6 weeks of treatment in these animals. We see that there may be liver dysfunction. But I'll get to the obvious critical question on what are the overall effects on cystic size. So focusing here on the left, we have renal cystic index. We see that the tolvaptan group does a pretty nice job of mitigating cystic progression in the males. We see that renal denervation had there's no statistical difference between these two treatments. So they have a very similar anti-cystic effect. And the combinational treatment, unfortunately, at this point is limited to just 2. So it's very, I can't make any assessments, and we have a pretty wide range of effects here. I will note that we didn't have much of an effect in the females in this cohort. They have a lesser renal cystic index compared to the male cohorts, and so perhaps maybe it's just underpowered because it's not necessarily that cystic at this point. But I want to highlight also that there was no beneficial effect, I guess, on renal cystic or a hepatic cystic index. So it seems that we're improving renal cystic index in the males with either treatment, but not really having much of an effect on the liver side. And so I'll stop there. I'll highlight my team that does an outstanding job driving a lot of these experiments forward. I want to highlight all my collaborators that have been outstandingly supportive and very helpful driving these experiments forward, as well as the funding. And I just want to take this chance to also specifically thank the PKD RRC for the early pilot and feasibility award, because that really launched us into this field of PKD, which has been exceptionally rewarding and has been really, really fun to dive into. And I'll just say also that they were a huge part in us securing our recent R01 in the application of renal denervation in PKD. So I have many of the people on the call today to thank for that. So I'll stop there and take any questions that you have at this time.
Christopher, thank you very much. Wonderful talk. As questions are coming in, I'm going to start off with one. If this was going through an AVP mechanism, right, you would expect the impact to be more on collecting or distal tubules,
yeah,
as opposed to the proximal tubules. Do you see that in any of your studies?
We haven't gone down to that level within our microscopic analysis. We're largely just looking at the overall cystic index. Mm-hmm. The way that we need to do that, though, is just doing isolated collecting duct cells and looking at the overall proliferative signaling. So that is on the docket.
I would encourage you to focus more on the in vivo than in the cell culture based stuff. You know, happy to discuss that with you offline at some point, why I think that, but
okay. Well, I mean, we have all the tissues sliced up and ready to go. So this would be an easy project retrospect or retroactively accomplish.
Just to let you know, something that hopefully will be coming out of the PKD RC sometime soon.
Okay.
The rat conditional models for PKD1 and 2, plus an RC version of the rat for PKD1. Those really of interest. So, you know, we had the PKD RC rat for a brief period of time, and the founder died on us, unfortunately. So we're regenerating them. But those may be of interest to you. Just let you know.
Absolutely. I mean, I'm only doing in the mouse because it's only available in the mouse. I
can imagine
this. Love to do obviously the electrophysiological experiments and the chronic experiments in the rat, because I just trust the telemetry
Well,
much more in the
I
rat.
can't imagine how difficult those surgeries have to be in a mouse. So kudos to you for getting those done. Those are not easy.
Yeah.
I'm going
Thank
to bring Michael up. Michael, you have a question?
Good afternoon. Thanks, Brad. This is Michelle Chancellor, University of Colorado. Chris, congratulations. This is wonderful data.
Thank you.
A couple of questions, and you may know about this more than I do. Doesn't renal denervation change the renal angiotensin system, expression of angiotensin II receptors? How much of this, of the cystic index, is being driven by this nice blood pressure reduction that you're seeing, and maybe modification of the RAS system?
So we have very, very mixed results. And admittedly, we did not do the plasma renin activity assessment in the PKD or in the PCK rats. But in our model of DOCA salt, we don't see much of an effect on plasma renin with renal denervation. So it doesn't seem to be through that mechanism. But I'd be remiss not to at least acknowledge that it could be partially through the renin-angiotensin system that renal denervation is having this overall effect. But that could easily be assessed as well with just chronic AT2 blockade with or without renal denervation to see if there's additional effects or similar effects. Yeah, that's not necessarily on our docket, but that could easily be a future collaborative experiment.
Very nice, Chris. Congrats. Thank you.
Thank you.
Sridhar.
Hey, hi, Christopher. First of all, thank you so much. That was, a really good presentation, and I liked it. My question is regarding cystic area and cystic index. Actually, you mentioned through whole presentation that we calculated cystic area compared with another things, and also we calculated a cystic index. So we all know that the cysts are developed gradually throughout the process, and also there is no specific time point which we can consider for the measurement for cyst, right? So I'm wondered how you calculated or what time point did you check, and it's not specific placed at a, stays at a specific place. So how you considered what are the criteria for that?
So maybe I'm misunderstanding your question, but we chose week 10 basically because these are the age of the rats in which we found had noticeable cysts, and we kind of backtrack or back calculated our way into this experiment because I don't really feel confident in our renal denervation efficacy beyond 6 weeks. And maybe this is news to many of you on the call. Renal nerves grow back in murine models. So it's very difficult to isolate or address our question directly without the convoluting effects of reinnervation over time. And so up to week 6, we do a pretty good job of keeping the neurotransmitter levels below 10%. Beyond that, I hesitate to go beyond that because it convolutes some of our interpretation of the data. And so at week 10 was when we thought was a good point in which we should address the early phase of disease, and that was about the earliest we could do a renal denervation in these rats is about week 4. So this is right after weaning. And so that was the rationale for the early phase. And at the late phase of the disease, we just wanted to be consistent with many papers in the field that address it at either the 6 or 9 month age. We chose 6 because we just were impatient. We wanted to get
So yeah, thank you. So you mean for initial stages you just observe it continuously, right? You observe it continuously, right?
No.
Then
So we only address the cystic index at the very end.
Oh,
Yes,
okay.
and so that I think I highlighted that, but maybe I didn't emphasize that very well in the talk. That we need to follow these studies, specifically in the late phase of the disease, is doing repeated measurements via the ultrasound and MRI to see if we truly have a reduction in cyst index or cyst volume, or just a blunting of the further progression, even at that late stage of the disease. That is something we'll directly address in the coming studies.
Okay, thank you. Thanks so much.
Yeah,
Steve.
thank you for your question.
Steve.
Yeah, very nice, very interesting work. Two quick questions. When developmentally does the renal innervation occur? And then the second question, you started to get into this when you talked about how there's natural reinnervation. I was going to ask just a naive question, whether you can experimentally reinnervate in any way.
Oh, so there's I'll address your first question and then dive a little bit deeper in a second. So the first one is when the renal innervation occurs. It's in utero. It's very early on. It's during the development of the kidney is the very, very early stages of the innervation. The second part is, can you replace innervation or nerve activity later on? The only way that I've seen this done, it's a very neat way, is through replacing the neurotransmitters back into the kidney following the innervation to see if there's any direct effects of the neurotransmitters on the tissue itself, absent any tonic changes in nerve activity. That has been done in this general area, but not necessarily within PKD. That is actually on the docket. That's actually one of our upcoming experiments, because that will directly address on whether there's terminal effects of the neurotransmitters. I say that because I'm not necessarily sold. It's sold on the idea that it's just through this ascending neurohumoral effect through the vasopressin mechanism, because we had this huge variation in response, but such tight data on the overall cystic burden effect. And so I'm not necessarily sold that it's just the AVP mechanism. It could be the terminal effects of just disrupting some of these neurotransmitters directly within the kidney itself.
Great, thank you.
Thank you.
Okay. Excuse me, Fung.
Yes. Yeah, thank you so much for the wonderful data. Very impressive.
Thank you.
Yeah, I have a general question about the innovation. I'm not familiar with that, but I assume that this innovation has an important physiological role. So if you do remove that system as you did, are there any adverse effect by itself? If yes, are there any other way to get around it? For example, using any drug, you can modulate the effect rather than remove anatomically that system.
Yeah, great question. So renal denervation by a catheter-based system in the clinical level, it actually has just been approved by the FDA. There's two different models of it through either the ultrasound catheter or the radiofrequency-based catheter system. In the early clinical trials, they directly addressed whether or not this is safe to do. There was concern that there would be an increase in renal artery stenosis since they're denervating from within the vessel. They found a few patients did have that, but there was no higher incidence of renal artery stenosis than the sham treatment or at the general incidence in this patient population. I will say that perhaps a negative side effect of this is the inability to vasoconstrict under hemorrhage. And so perhaps maybe just avoid sword fighting, I guess, after renal denervation. So that could be a negative side effect, but overall, it does not seem to have many negative side effects that have that have been observed at the clinical level, and it's been approved to be safe and efficacious for the treatment of hypertension, which I'll actually pull up a slide just to make sure that everyone is aware. These are the new systems that have been just approved just in the fall here. The spiral catheter system through Medtronic, as well as the Paradise system, the ultrasound system. They've both been shown to drop blood pressure following catheter-based renal denervation.
All right, Lisa.
So Chris, that was a beautiful talk, and so many
you.
exciting aspects. A couple of a comment and then a couple of questions. So the comment is that it's really interesting that the PCK rat, and you are obviously well positioned to be able to say definitively it doesn't have significant hypertension, because that's obviously quite different than what you see in the human disease.
Yeah.
That said, the cysts in these rats are very similar to the human cysts. As you know, it's dilatation, not the ADPKD phenotype. I think it's appropriately conservative for you to say, well, you know, the kidney size goes down and we're not sure if there's some diminution in the cystic index, again, dilatation, you know, the continuity of the nephron is open, or if it's something else. But what's really caught my eye is the GFR. And I wonder, have you been able to look at that effect over a period of time? Because that would really be the sort of the money piece.
Yeah. We haven't gone beyond the 6 weeks, unfortunately.
Yeah.
So I have a cohort of rats set aside actually right now that we did the denervation just very early on at week 4. And I'm throwing out my concern of the 6-week limitation, in which I've kind of self-imposed.
Right.
And we're just going to age them out.
Right.
And we're going to periodically, I think monthly is what the plan is right now, is just measure GFR and take a couple of measurements, such as serum BUN and creatinine, to see if and when the renal function declines.
Right.
Yeah, you and I are in complete agreement on that.
Right.
That's truly where the moneymaker is, I think, in that.
Well,
Yeah,
and these devices are clearly approved for adults, and the kids with the most aggressive disease, as you well know, are really very little babies.
yes.
Second point is in looking at the liver phenotype, I might suggest that if you're really looking for an effect, the early phenotype is dilatation of the terminal branches of the biliary tree. But then the disease as it is expressed in humans, and I think also in rodent models, for whatever reason, that dilatation, that epithelial injury seems to trigger an inflammatory response with associated inflammation and fibrosis. And so thinking about not just a cystic index in the liver, but the extent of the fibrosis in the portal triad might be a better marker. Because it's remarkable to me. I mean, we all know that the kidney and the liver have a crosstalk, but that you diminish the function of the renal nerve and you see an effect in the liver.
Yeah. Okay. Luckily, our slides are stained with Mason's trichrome.
Perfect.
So, I will make a note and have one of the students go back and look at that right now. Thank you very much for that comment.
Great work.
Yeah.
Yeah, great talk, Chris. To follow up a little bit on the liver, we know that in PKD patients, polycystic liver disease occurs frequently and associated with mass effect and pain problems. So I was wondering, and of course, tolvaptan really doesn't seem to help there. There's no vasopressin 2 receptors in the liver. So I was wondering if liver denervation is possible or feasible in the PCK rat model or ever used in patients. I did see in the literature a report of obesity-induced hepatic steatosis where they did sympathetic denervation and saw a dramatic improvement. So I was wondering if you've considered looking at that.
Yeah, I'm familiar with some of the work that's been done in steatosis model, the non-alcoholic fatty liver disease. I'm not sure of our ability to do the hepatic denervation. I haven't tried it. I also want to highlight that the kidney, there are many reasons why I love the kidney, but one of them is that I can easily assess the nerve contributions to the disease because I can isolate it specifically to just the sympathetic, the spinal innervation, because there's very little evidence, if any, that there's parasympathetic innervation. And so I strictly focus within the just sympathetic contributions to overall disease progression. I'm able to kind of isolate parasympathetic, at least directly, on the kidney. That's not the same when it comes to the liver and many other organs in the body. With that said, there are a couple of techniques, chemical techniques that are not necessarily the mechanical denervations that we do, that could isolate sensory nerves, but also sympathetic nerves, and keep it still within the context of sympathetic innervation. But it's required, you need to perfuse the liver with those chemicals. And so isolated perfusion preps are going to have we're going to have a very difficult time doing that. And so I think I know my limitations as a surgeon, but I'm more than happy to at least consult or help others to try to do that. We can certainly attempt, but I will admit that is not our forte.
Thanks.
All right, any other questions?
I actually have a question for others.
Okay.
If anybody can comment on this was actually, I did not expect this sex difference following tolvaptan treatment in these rats. So the PCK rat you see here is given tolvaptan on top of renal denervation, and we see that the females specifically have this huge polyuria and polydipsia following tolvaptan treatment, whereas we do not see as much of an effect in the males. Can anybody help me out here and comment on this? Because I'm kind of looking for a way to attack this mechanism a little bit.
That's an interesting question, and it's out of my area. So, anybody?
I mean, we could be looking at just V2 receptor expression, and to see whether or not it's higher in the females versus the females.
Yeah.
That'll be an easy way to address it via Western blot, but I'm more than happy to hear anybody's opinions.
Lisa.
Yeah, so this is not the PCK rat is an autosomal recessive trait, and you would expect that it would be, there would be no sexual dimorphism. But we know in a number of rodent models there is sexual dimorphism in just the progression of the disease. And I wonder if what you're seeing as a treatment effect is related to a fundamental mechanism that occurs in rodents, and that at least we don't appreciate it in humans. And so it may not be a treatment effect per se. It may be something you're seeing because there is a baseline there. And I think there has been, and I'm a little rusty here, I would need to go back and look at the literature, but I think there has been a report talking about different disease courses with the sexes.
Okay. My suspicion is it's just through simple receptor expression, but we obviously have to do the Western blots just to see another hand.
Oh, sorry. Sarit, go ahead.
Yes, hi. Thanks for the talk. It's very interesting. And I actually was following the clinical trials years ago. So it's good to know that it's approved. Just note about the female versus male. I don't know about specifically the kidney, but with the liver, there is a huge difference between female and male because of other factors which affect cyst growth, such as estrogen. So it could play a role in the kidney as well. I mean, I haven't seen any research done about that, but I've definitely seen research done in the liver. So we shouldn't forget other factors. The other question I have regarding the innervation is kind of slowing down progression of cyst. Are we talking about the existing cyst growth, or have you looked in formation of new cysts? And again, it's going back to the question of the chicken and the egg, because it's very important whether we are actually preventing formation or slowing size increase, because at the end of the day, you really want to know what's your ratio between healthy tissue and normal.
Yeah.
How much parenchyma you still have left. So we looked into that.
Yeah, so our recent study that we did, not with the paired tolvaptan treatment, but with this in the 6-month cohort that we did the denervation technique, and I posed to you 2 different explanations. The reason why there's just a little bit of data that's kind of getting me excited about this second explanation being potentially true is that we failed to detect any changes with the urinary clearance of cyclic AMP or the Ki-67 staining. There was no difference between the treatment groups, which would suggest that we're not necessarily affecting cell proliferation. And so if we're not affecting cell proliferation at that point, trying to rule out any other systems that would be explaining this beyond just potentially changing transport and regulating fluid volume or cystic volume in this. And so this is obviously something I'm very, very keen on addressing. We just need the tools to do it.
Thank you.
One way that we're trying to do it right now is through the renal organoid system, and seeing if there's any direct effects of some of our neurotransmitters directly on the cyst progression itself. But we're also going to be looking at the transport across there between the inner cyst and outside with the presence of these neurotransmitters to see if there's an increase in maybe permeability.
Yes, thank you. That's a very different, aspects of the disease.
Yes.
The proliferation in my mind is like the main goal, but permeability is also something. Yeah, thanks.
Yeah. And I just want to make this overall just general kind of statement of renal denervation applied to PKD is that obviously this is not an end-all cure kind of treatment. What we potentially could be doing is buying time, which is the most valuable commodity that we could be giving some of these patients. And so I think that there's a lot of potential with the recent approval of these catheters. You have 2 different catheters that you could choose from, and both have been shown to be safe and efficacious. And I think that this could be shoe-in through for some of these patients, at least ADPKD, because they also present with hypertension. And so since it's approved for the treatment of hypertension, perhaps this could be evaluated at the clinical level. I'm a basic scientist. I don't do that. I'm just really trying to allow those in the clinic to potentially address that. So I'm happy to discuss that with any of you following this. Please reach out to me anytime.
Buying time is also great. So, I mean, say as simple as even getting to the 3D printing organs which you can transplant. So buying time is big.
Agreed. We are right at the hour, so I want to close this down again by thanking Christopher for a wonderful talk and the audience for insightful questions. And if there's anything that we can do, Christopher, to help advance your program, please do not hesitate to reach out to us. We're here to help in any way we can. Okay.
Thank you all very much. I really appreciate your time and attention. Have a great summer.
All right. A great way to end it. Thank you, Christopher.
See y'all.